Hi, it's Tim from ChiroUp. This week's blog is about the #1 cause of lateral hip pain, and that is gluteal tendinopathy. In fact, 1/3 of our lower back pain patients have gluteal tendinopathy concurrently. This condition is so common it's been dubbed rotator cuff tears of the hip, not only because it's common, but it also shares a similar etiology. That most tears of both the rotator cuff and the gluteus medius tendon occur on the undersurface. Remember, the gluteus medius tendon comes off the iliac crest, runs down onto the greater trochanter, and tears, just like in the shoulder, start on the undersurface. So that tells us something, that the etiology is not tension, but rather compression. Let's look at this piece of rubber tubing. That if it's straight, it has relatively similar pressure on both sides. But if I bend this, say, over the top of a humerus or over the top of a greater trochanter, now there's a lot of tension on the top side. There's a lot of compression on the underside where it starts to buckle. Well, almost all tears of these tendons start on the underside, which tells us compression is the culprit. Yes, in lateral hip pain, it's not the bursa. We've de-emphasized that. We know that it's not bursitis, and even when bursitis is present in less than 1 in 5 cases, or changes to the greater trochanteric bursa, that's not the problem. It's chronic compression. Great news, there are 3 tests with very high sensitivity and specificity to help us identify this. The hip lag sign, the 30-second single leg stance, and the external derotation test. Both of these have greater than 90% sensitivity and specificity, and in the blog, we're going to detail each one of those. We'll also talk about the treatment, which not surprisingly is trying to reduce compression in the area and to improve faulty mechanics so that the patient is no longer doing the things that aggravate it, like weakness of the hip abductors, running improperly, sitting and standing improperly. So we're going to talk about how to get rid of those things and how to progressively rehab that. It has to be a strategic plan because initially we want to not do things that cause increased compression, like letting the patient's legs adduct together, but ultimately they're going to need to be able to do those things. So we want to use some clues. One of my favorite is change in nighttime pain. That helps me gauge how do I progress the patient. If they have an increase in nighttime pain, I've probably advanced their exercises too quickly. And if their nighttime pain continues to fade, we're moving at a good pace. I hope you'll enjoy this blog. There are 10 awesome tips from our most recent protocol on gluteal tendinopathy. With the help of our advisory board, we've put together something that you can use in practice, and I hope that it helps you get better outcomes and that together we continue to march on to become the undeniable best choice for patients and payers alike. Thanks for watching.